This is a demonstration of an endotracheal intubation of an infant in the NICU with suspected or confirmed COVID-19 infection. COVID-19 is spread through droplets. However, aerosol-generating medical procedures or AGMPs such as endotracheal intubation can increase the risk of transmission of COVID-19 for those present during the procedure. Therefore, modifications to usual intubation practice are needed to minimize the risk posed to healthcare providers when intubating an infant with suspected or confirmed COVID-19 infection. Because the likelihood of vertical transmission is very low, the highest risk is likely to be in intubating symptomatic infants with postnatally acquired COVID-19, such as those presenting with bronchiolitis or pneumonia. In this video, we will discuss some guiding principles in minimizing the risk in intubating these infants in the NICU. First, minimize the number of team members involved. Second, ensure the proper use of personal protective equipment, including the N95 mask. Third, minimize the use of manual breaths using bag mask devices or PPV. Fourth, minimize the exposure to the intubator, such as with the use of a video laryngoscope. Finally, ensure a closed circuit, such as using a cuffed endotracheal tube in appropriate infants. To minimize the number of team members exposed, the team inside the room during the procedure should consist of an experienced nurse, respiratory therapist, and the intubator. Only experienced intubators capable of troubleshooting a difficult airway should attempt these intubations. No learners should be in the room during the procedure. However, to facilitate a rapid response as needed, additional team members should be readily available outside the room. These team members can assist with equipment preparation, recording, and the provision of emergency equipment. In the event of a failed intubation, a backup intubator should be readily available. Ensure the proper use of personal protective equipment, including gown, gloves, a properly fitted N95 mask, and eye protection such as goggles or face shield. If available, the use of a spotter to guide proper doffing or removal of PPE after the procedure is crucial in preventing self-contamination. A spotter can also be helpful in ensuring the proper donning of PPE. Bag mask ventilation using devices such as the T-piece is an aerosol-generating medical procedure. If possible, avoid the delivery of manual breaths using these devices before and after the intubation. Consider pre-oxygenating using low-flow oxygen or increasing the FiO2 on the infant's current respiratory support. Rapid sequence induction using back-to-back fentanyl and succinylcholine may decrease the need for manual breaths. After the endotracheal tube is placed, directly connect it to the ventilator to avoid manual breaths through the bag mask device. However, some infants may require bag mask ventilation to maintain stability. Consult with your unit to determine if viral filters are available to be fitted on your bag mask device. It is important to minimize the exposure to aerosols to the intubator and to the team. By only utilizing experienced intubators, we can minimize the number of intubation attempts and the duration of attempt, which protects both the intubator and the team. The use of a video laryngoscope increases the distance between the intubator and the airway, and should be considered if the intubator is comfortable with this technique. In difficult airways, consider the use of a laryngeal mask airway after 2 failed attempts to decrease ongoing exposure to the team and to allow for additional help to arrive. Promptly creating a closed circuit from the patient to the ventilator minimizes the aerosols generated. In appropriately sized infants, generally above 2 kilograms, consider the use of a cuffed endotracheal tube and inflate the cuff as soon as possible, preferably right after the tube depth and position is checked at the bedside. The cuff should be carefully checked and maintained. Connecting the endotracheal tube and the end-tidal CO2 directly to the ventilator rather than to a bag mask device also helps to create the closed circuit. Minimize disconnects if possible, and if needed, such as to attach an inline suction, minimize the amount of time the endotracheal tube is disconnected and consider careful clamping of the tube during the disconnect if appropriate. Having 2 doses of succinylcholine readily available at the bedside reduces the risk of inadequate muscle relaxation and reduces delays when a second attempt is required. If possible, have a recorder document the procedure from outside the room. This can be assisted with the use of two-way communication devices. Finally, closely follow unit infection control guidelines for the cleaning and disposal of equipment after the procedure. We will now show a demonstration of the procedure. To conserve N95 masks, they were not used in this simulation. In actual intubations of infants with suspected or confirmed COVID-19 infection, all team members in the room during the procedure must wear appropriate PPE, including gown, gloves, N95 masks, and eye protection. This term infant was admitted with symptoms of bronchiolitis as well as household COVID-19 contacts. She is developing increasing respiratory distress on low-flow oxygen. The use of non-invasive respiratory support such as CPAP or NIMV is also aerosol generating, and given the history and severity of respiratory distress, the team would like to intubate. Consider increasing the low-flow oxygen while the team is setting up for the intubation. The bedside nurse who is caring for this infant will be part of the intubation team. She will hand off to a nurse in contact and droplet precautions, who will monitor this infant while she herself doffs her PPE and joins the intubation team outside to prepare. As much equipment preparation as possible should be done outside of the patient room. A table can be used to collect and arrange all the necessary equipment. Even when planning to use a video laryngoscope, have a direct laryngoscope ready. Also, have 2 doses of succinylcholine drawn and ready as well. If a cuffed endotracheal tube is used, be sure to check the cuff by inflating and deflating the cuff with a syringe and have the syringe ready. All of the ventilator setup can be done outside of the room as well. Set up the ventilator on the tanks. Doing this will allow more flexibility in where the ventilator can be placed during the procedure. It will also allow the respiratory therapist to connect the ventilator to the wall gas outlets after the intubation to decrease the workload prior. Connect the circuit to the end-tidal CO2 and a test lung. The ventilator settings can then be entered such that the ventilator can be started prior to the intubation. The team should perform a prebrief outside of the room to go over the roles and the intubation plan. All members of the team should be clear with regards to the changes to usual intubation practice due to COVID-19 precautions. It may be helpful to use the intubation prebrief checklist. Additional team members, including the neonatologist, should be made aware that the intubation is about to proceed. At least one additional team member, such as a second nurse, should remain outside to provide support if needed. The team will then don appropriate PPE outside of the room, then proceed into the room, bringing in the equipment with them. Any individual other than the 3-member intubation team, such as the nurse currently in the room, should now doff their PPE, leave the room, and close the door. The intubation can now proceed. Consider giving the atropine early to ensure that it comes into effect. The respiratory therapist will now set up the ventilator. The end-tidal CO2, already on the ventilator circuit, is connected to the monitor. The ventilation circuit is placed close to the infant for easy access. The ventilator is then started. It will ventilate the test lung. While we wish to avoid bag mask ventilation, the bag mask device is checked in case it is needed. A viral filter has been fitted between the mask and the T-piece. If possible, have the recorder outside the room. All of the equipment, including the video laryngoscope, is ready. When the intubator is ready, fentanyl and succinylcholine is given back to back. Once adequate muscle relaxation is achieved, laryngoscopy begins. Once the tube is placed, the depth is checked and noted. When checking the tube depth, attempt to do so as far away from the infant's face as possible. The tube is directly connected to the ventilator. Placement is checked by auscultating and by end-tidal CO2. If using a stethoscope, ensure that it is the infant's own stethoscope or that it is cleaned appropriately after the procedure. The cuff is then inflated. The endotracheal tube is then secured by a usual procedure. The used equipment should then be disposed of or cleaned per infection control guidelines. Special equipment, such as the video laryngoscope, need to be handled with care. Wipe down the blade and deposit it in a bag held by a clean assistant to be removed with cleaning. The video monitor itself should be carefully cleaned per guidelines as well. Careful doffing or removal of PPE is key to avoiding self-contamination. Follow the posted signs, and if possible, use a spotter to guide your PPE removal. Remember to perform hand hygiene after every step and to avoid touching anything but the straps of your N95 mask. Some final points. How you enter and exit the room will depend on your unit and on the presence of an anteroom. Check with your unit guidelines. In general, use a negative pressure room if available and a single patient room if not. Keep the doors closed during the procedure. If you are continuing with patient care, doff your gown and gloves, exit the room, and re-don new gown and gloves. Thank you for watching this video. We hope it is helpful. As information is evolving rapidly, keep checking your unit guidelines to keep up to date. Stay safe.